see everybody's mostly got lunch, which is great. We'd like to start reasonably on time. So thank you firstly to Castle for organizing the session. And thank you to Jensen for sponsoring, as well as for Peerview for actually organizing the session today. As you can see, it should be a debate. So debates are supposed to be fun. We have in the red corner Dr. Shafran from the University of Alberta. So he is an infectious disease person arguing at a liver disease conference. I'll just leave it at that. And then we have Dr. Shah from Toronto Western Hospital. And he'll be also arguing on the opposite side of deferring therapy. And Dr. Shafran will be doing a treat now. A couple of housekeeping points. We do have one of these punch button systems. Apparently, you're not allowed to take it home today. So if you've taken them home in the past, that's all right. But today, you have to leave them here, if you could, please. These are our disclosures. Look at how terrible these two are. These two are terrible. Terrible, terrible. OK. So with regards to questions, there were a number of questions actually emailed to us prior to the event. So we'll go through those questions at the end. There is a sheet in your folder for questions if you don't want to actually stand up. But otherwise, you're more than welcome to stand up at the end. And we'll take any questions for the two speakers. If you can understand this slide for the ARS system, you're in the wrong room and, in fact, the wrong conference. Good. No one left. So the learning objectives this afternoon, to understand the latest data with regards to hepatitis C and its impact on clinical practice, discuss the benefits and challenges of prompt initiation as well as deferring therapy, and really how to take these learnings into the clinical setting. So let's use this thing, the ATS apparently. So you can vote of why you're actually here, and I'll usually try and give you about 15 seconds per vote. So what brought you here to this debate? Can you press enter? Because I can't. Thank you. That's interesting. To learn some. My goodness, what is wrong with you people? They're not here for entertainment. You two are going to lose. To what speakers below the belt. That's easy. So if you're going to heckle them, please heckle them. It makes my life easier. So as any true Canadians, this is how it should be. There are no rules for this debate. You can give any data if you want to. You can give no data. You can give opinions. You can give somebody else's opinions. We don't really care. OK, Hemant and Steve? OK, this is actually one of those back to the serious questions. In the past month, what proportion of patients with hepatitis C genotype 1, stage 2 fibrosis, have you deferred for a newer PEG-based therapy? And I said PEG-based, newer PEG-based therapy. So I'm looking for semaprevir or sofosbuvir-based therapy for the future. Yeah, let's do an enter. So most people are less than 10%, but there are a third of people who are actually almost deferring everybody. OK, so we'll see what that looks like at the end of the debate. So in the last month, what proportion of Hep C genotype 1 cirrhotic patients are you deferring for future PEG-based therapies? OK. Oh, oops. Can you repress it, I think? Ah, OK. So less than 10. So you're actually treating most of your cirrhotic patients, but thinking of deferring the stage 2s. OK. Steve, you're on first. Because, you know, there's our Hammond. He's just going to take a snooze through all this easy part. So Steve Shafran is from the University of Alberta, a clinical professor in infectious disease. Thank you, Steve. You'll need that.
I will. Thank you. Thank you very much. It is a pleasure to be here, and thank you for the invitation to debate with Dr. Shah. It was interesting you showed that hockey slide because Dr. Shah wasn't even born the last time the Toronto Maple Leafs won the Stanley Cup. Now, why are we treating hepatitis C? We treat because we want to get clinical outcomes that are meaningful. We treat because curing hepatitis C saves lives. You can see here that we have reduced overall mortality and reduced liver-related mortality. And the interesting thing about this study is it included patients from the Toronto Western Hospital. So Dr. Shah, where did you say you work? I think Somewhere nearby, yeah. And not only does curative therapy save lives, it actually prevents cancer. So people who are cured of hepatitis C have a significantly reduced but not absent risk of liver cancer, even at the Toronto Western Hospital, where Dr. Shah works. And we know from this work from Gary Davis that we have this bubble cohort effect of aging boomers who are getting progressively advanced liver disease, and the biggest burden of advanced end-stage liver disease and liver cancer is still yet to come. But Dr. Shah doesn't think we should treat them. You know, and it is an interesting realization in the US last decade that we see the rates of mortality related to HIV go down while those of HCV have gone up. And it's hard not to notice that with HIV, we treat almost everybody and suppress virus in almost everybody. And with hepatitis C, we treat very few people. And in that era, we couldn't even cure 50% of those who we even tried to treat. So coincidence? I don't think so. So Scott Holmberg at the hepatitis division of CDC did this cascade, and the treatment cascade was discussed initially in HIV, now adapted to Hep C, and for every 100 patients in the United States with hepatitis C, 6 are being cured. And my colleague Dave Thomas at Hopkins published this a few years ago, predicting in 2010 when he published this that before 2018 we'd have regimens that could cure 90% of patients. And yet, he pointed out, if we don't change the number of people we treat, we're going to do nothing to the global impact on treatment. So having drugs that can cure 90% is great, but if you don't treat anybody, it doesn't do anything. So you got to treat people. So we've gone from the pre-DA era to the first generation DA era, and now we have the first generation DA still used in combination with PEG and RIBA, but Dr. Shah doesn't think it's good enough. Dr. Shah wants 100%. Dr. Shah, perfect is the enemy of the good. So, so Dr. Shah is waiting for Godot. Now, this is an incredibly great play. For anyone who get a chance to go to New York in the next month, it's on stage with Patrick Stewart. So if you go to New York, you should take advantage. But I will spoil the ending of Waiting for Godot, so he doesn't come. Okay? So 100% SVR, it's not coming. So why are we treating? I'm going to start with the lowest hanging fruit and move up the tree. So with genotype 2, we can cure right now about 80% of patients for $10,000, so the cost per SVR is $12,500. Dr. Shah wants to treat them with sofosbuvir and ribavirin for $55,000 and a cost per SVR of $58,500. That's what he wants you to do for 4.7 times. Whereas in fact, if you treated everybody now and then took the 20% who failed and spent the big bucks on them, you would cure everybody. You'd cure 97.2% for $21,000. So why would you wait? Genotype 3, cure rates are a little bit lower, so your cost per SVR is a little higher. It's $14,300 with PEG-RIBA. But if you want to treat them with sofosbuvir and ribavirin, that's $110,000 a course, $118,000 per SVR. That is just madness, and it's just not going to happen in the Canadian environment. So G4 to 6, well, 5 and 6, nothing else is approved but PEG-RIBA. You got to treat them. G4, sofosbuvir is approved in combination with PEG-RIBA. And when do you think we're going to get that? We can cure 2/3 of the patients now with PEG-RIBA. Why aren't we doing that? So let's move up to the top of the tree and talk now about genotype 1. Why would we want to treat genotype 1? Well, we've got tons of genotype 1 treatment-naive patients, tons of them out there. And we have a small number of relapsers to PEG-RIBA who have yet to be treated. And when you put these together, you're looking at patient populations that have very high rates of SVR, the vast majority of whom can be treated for an abbreviated course of therapy. So within the genotype 1 family, these are the ones that definitely should be treated, and we can fill our nursing capacity. In my program, we treat 120 patients at a time. We have a waiting list, and we're treating patients with a high probability of cure. And if we cure them now, we free up treatment capacity in the future. If you want to put your nurses on unemployment for 3 years and rehire them back in 3 years, or 4 years, or 5 years, good luck. So that's what you're proposing we do. So we have lots of medically suitable, willing, treatment-naive, and previous relapse patients to fill all the spots in our programs for years to come. We're looking at SVR rates in the 75% range. Most people will be treated for a brief period of time. If you look at the value for public money, the cost per SVR is really quite favorable. It really doesn't make sense to wait for Godot because he's not coming. So we still have a subgroup of patients that do need to be treated now. They're numerically few. We have people with extrahepatic disease. We have women who want to get the virus out of their system before they have their babies to stop that small risk of transmission. We have surgeons and dentists who can't practice until the virus is out of their body. We have people who refuse life and mortgage insurance with Hep C, and they can actually reapply after they're cured. And then we have motivated patients. And you get some patient coming out of a rehab program, and now they're finally motivated. They come to your clinic, and you say, come back in 3 months. So they'll go find their dealer, and maybe they'll come back, and maybe they won't. You have to get them when they're motivated. And saying no isn't the solution to them. So there's a lot of people you can treat. You can keep your clinics going for a very long time. And if you look at a poll that was just published, done through members of ASLD, most of who, 80% of who were hepatologists, the majority are treating. This is 2013 data that was just published. Most are treating except sort of 50-50 on the post-transplant arena. But in all the other categories, the majority of hepatologists in the survey says, treat now. So, and there are consequences of not treating. You know that patients get lost to follow-up. Remember that one you saw in 09 who comes in now with a variceal bleed? Yeah, that guy. People get lost to follow-up. As they get older, their fibrosis advances, they start to get heavier, they start to get comorbidities, type 2 diabetes, fatty liver, statins, and all the rest of the stuff. You can take that off the table by treating them now. And of course, they're still communicable too. And then there's also the cost of non-treating. So a patient you defer for treatment later, how many visits, lab work, ultrasounds, fibroscans are you doing between now and 5 years that you wouldn't have to spend if you treated them now? So that's part, you won't include it, you don't think it's in the package, it's in the package. It's public health care dollars you're spending in the next few years instead of just treating them now. So many patients should be treated now, especially treatment-naive patients of all genotypes and genotype 1 relapsers. The SVR rates are in the order of 75% for these patients. We can fill the Canadian hepatitis nursing capacity for quite a long time doing this. And let's not forget how slow public funding of first-generation DAAs has been. And even when it's funded, it's been with restrictions in all but 2 provinces. It's really very, very likely that we're going to have even more restriction on the interferon-free therapy. In fact, it may be restricted to people who failed triple therapy, in which case you let their fibrosis advance and lower their probability of SVR. So yet another reason to do that. So willing patients are the ones you treat. You need to treat them now, and you shouldn't turn them down. So thank you very much. Now it's my turn to have a drink.
That was fantastic, Steve. It's actually really good. So now we can blame Hemant. If you defer therapy, it'll cost the system too much. The nurses will be unemployed. I think when I catch my flight home and it's late, I'll tell my wife it was Hemant's fault Air Canada left late as well. So Hemant, it'd be my pleasure to introduce it. Hemant is going to talk about deferring therapy, and I'll leave it to you. Thank you.
Thanks very much. Thanks everyone for attending, and thanks to the organizers for inviting me. It's truly a privilege, actually, to debate someone of the stature of Dr. Steve Shafran. He's from Alberta, and he's already done something very Albertan, which is to, as any Albertan politician would do, just completely fragment the debate into multiple small pieces and try to carve out his little niche of and sort of pitting one group against each other. I found it ironic that he did talk about the Toronto Maple Leafs. I'll remind you that Wayne Gretzky is now 50. If that's your memory of the last Stanley Cup. I think the Leafs, though, will win the next Stanley Cup out of these 2 teams, so I hope to be alive for that one. The other, when we're talking about Edmonton versus Toronto, we should also look at our legacy of carbon emissions over here. So on the left, we have our wonderful oil sands. On the right, we have the green energy movement of Ontario. So I think we sort of win there, too. This is truly below the belt, and there's no way as a Torontonian I could possibly defend that, so I will just move on. Now, what factors matter when you're deciding to defer treatment? And I think Dr. Shafran has introduced a few of them, but let me round them out. So for the patient, what matters? What matters is need for treatment and motivation for treatment. What about the treatment itself? I mean, Dr. Shafran talked about costs, but notice he didn't talk much about efficacy or safety and tolerability of treatment. Those are actually at the patient level extremely important. Dr. Shafran's been doing this for a long time. He probably forgets what it's like to deal with individual patients. And at the system level, cost and capacity, and we've heard a little bit about that. To be honest, I'm surprised the guy from Alberta is making a cost argument. Hepatitis C, remember, is an intermediate pathogen. Fibrosis progresses slowly. Infected individuals can wait. We're not talking about 2002, where PEG-based therapy was introduced and the next treatment was coming maybe 9, 10, 11 years from now. We're talking about 2014, and your next treatments are already on market. You're just waiting for them to be approved for the majority of your patients. You're not waiting for them to be developed and trialed. And remember, the rate of progression to cirrhosis in our patients, even those with advanced fibrosis, which is the gray line here, is slow. Median progression for a patient with F3 on biopsy to cirrhosis is 5 years, okay? That's a long time. That's not months. That's 5 years. And even your patients, once they develop cirrhosis, their time to decompensating event, really when you're going to modify their risk of success on treatment, is slow. In the first year, that bar barely moves, actually. So your patients can wait. That's a critical thing to understand here. And it's a false dichotomy to say, well, you're going to treat your patients now or you're going to do nothing. Dr. Shafran's accusing me of wanting to do nothing, but it's not doing nothing. The argument about treatment or deferring treatment is treating with anti-Hep C treatment or focusing on other important issues for your patient. So from a lifestyle point of view, if you defer treatment for some of your patients, you can focus on alcohol abstinence. You can focus on weight through diet and exercise. You can get them to drink more coffee, get them to visit the Tim Hortons in your hospital. And from a monitoring perspective, it's not like you're going to leave these patients to sort of, fend for themselves for the next year. You're going to bring them back for their routine ultrasounds. You're going to perform some blood work. You're going to communicate with their primary care providers. So this is not treat or do nothing. This is treat versus defer. And the other thing I want to remind you about this debate when we're talking about setting terms is it's not treat now. The goal is to SVR now. All right? And that's different. We are aiming for cure now in hepatitis C. The modeling that, that Dave Thomas has done, that Gary Davis has done, that all is about treatment. But maybe we need to flip the paradigm and talk about how are we going to get people to SVR. And I would argue that actually deferring your patients today to get them on a treatment that's better later is a better way ultimately to get them to SVR and to get more of our population to SVR. So yes, this is a graph that's already been shown. And it just makes the point that these are not patients whether or not they've been on treatment. These are patients who've been on treatment and whether or not they SVR'd. So putting a patient on a treatment that's not going to predictably lead to SVR, you're still walking up this part of the bar. To get your patient to this part of the bar, and yes, these were patients from Toronto Western, some of them, is SVR. There's a difference. Now, out with the old, in with the new. I was going to put actually Steve's face on this slide, but I thought we'd better just talk about the treatments. There were a few people that wanted below the belt comments, I think. These are our current treatments. We have boceprevir, 12 tablets a day. We have telaprevir, 6 tablets a day, taken at very specific points of time. We have the high-fat content meal that individuals have to ingest. We have all the transfusions and management of anemia. This is the patient experience of treatment today, okay? That should be something of the past. This is what the future is. We have cimeprevir, 1 tablet a day, sofosbuvir, 1 tablet a day. And your patients no longer need an alarm clock. All they need is a calendar, because they're going to be done treatment pretty soon. And in fact, side effect management for the physician is going to look a lot more like lying on a beach than it is what it looks like today. So the patient and physician experience when you wait for new therapies is going to dramatically change. And when we talk about capacity, I mean, are you going to be capable of treating more patients when you're doing all of this, or more patients when you're doing this? Every patient group has better SVR rates with new therapies. Okay? So let's look at patient groups by genotype. So I will say these are the slides. This is like the worst thing about doing a debate, which is you put slides of various studies that are not cross comparisons together. But we all do this in our head, so I thought I would do this for the group. So this is for genotype 1. All right. So boceprevir, pegriba, telaprevir, pegriba. We've already looked at that. Actually, I'm going to switch. This is cimeprevir, pegriba. SVR rate of around 80%, sofosbuvir, pegriba, SVR rate of around 90%, and then the coveted cimeprevir, sofosbuvir combination therapy. That's like the 10-star therapy. We give it a conservative estimate of maybe 93 to 95%. So this is your comparator now, actually. And I would argue that if I showed you this slide and said, which treatment wouldn't you want your patient on, you would probably draw the line somewhere right here. Right? And you say, yeah, this all doesn't look too good. For genotype 2 and 3, while the absolute increases in our SVR rates from our existing pegriba therapy across the various groups may not be as much as we see in genotype 1, we are still looking at least equivalency, if not improvement, across every patient profile, not to mention dramatic improvement in the patient experience. 12 or 24 weeks of an all-oral therapy compared to 24 weeks of pegriba is a significant improvement from that perspective. And when all you talk about is cost, you ignore that part about the patient living through it. How about fibrosis? So if you have patients who are cirrhotic, genotype 1 cirrhotics, this is not even including that 10-star combination of sim-sof-riba, which would be even higher. We're talking, again, improvements across the board. And finally, how about patients who are treatment naive and treatment experienced? Those patients we haven't lost to follow-up in our practice. We are also seeing improvements across the board for those patients. So, and across every genotype as well. So I think, when we put it all together, we need to really understand that hepatitis C infected persons can wait for therapy. They can wait a year. They can probably wait 2 years. Recently approved medications are safe. They very importantly enhance the patient experience. They have better efficacy across the board. And I would argue that deferring treatment is the best recommendation you can make to your patients today. Thank you.
Dr. Shah, that was fantastic. Steve, you've got big problems. Either you show some good data or you just get dirty. All right, my friend, this is...
Well, in preparing for a debate with Dr. Shah, I went to the most reliable source of medical information you can go, which is ratemd.com. So he got a 4.7 out of 5. So that's actually very good on ratemd.com. And when I come to think about it, it does make sense because he's been mentored by the finest minds in the hepatitis C world. Okay, like here he is with one of his mentors. Okay, here he is with yet another one. And here's where you learned everything about genotype 4. So, and then I look at, some of his publications, and I see that, you recently had this paper about screening for hepatitis C. Is it time? And go to the UHN website, and he's interviewed about this paper, and they say, hepatitis C is a life-changing diagnosis, yet there's a huge gap in public and healthcare provider awareness about the disease, its implications, and the treatment options for patients. And he goes on to say that to impress on everyone that early diagnosis and intervention can prevent much of the damage of the illness. So I don't know what intervention he's talking about because deferral doesn't strike me as an intervention. So that Dr. Shah is actually correct. We do need to test more patients for hepatitis C, and we definitely need to treat more patients for hepatitis C. But this Dr. Shah, I don't know where he's coming from, but I did figure out where he's coming from. This is where he's coming from. Okay. That's right. He's living in Fantasy Island. And everyone who goes to Fantasy Island gets to tell the boss in Tattoo about their fantasy. And here's his fantasy. His fantasy is that everybody is going to, that there's going to be mystical money to pay for these new hepatitis C treatments. And he just told you it's all about the patient experience. He's also going to tell you everybody should drive the top of the line BMW too, right? Because it's the driving experience. So that's what he thinks is going to happen with this. So let's teach him a little bit about the new math, okay? So there's a pill that costs $655 for a pill. And actually, if you could afford 15 of them, you could treat a genotype 2 or 3 patient today. And if you could afford 30 of them, you could treat a genotype 4 patient today. However, it takes 84 of them to treat genotype 1 and 2 and 4. And it takes 168 if you want to treat a genotype 3. And frankly, for the cost of that, you can buy a condominium in Winnipeg. We can have a separate debate about whether you want to have a condominium in Winnipeg, but you could. So Dr. Shah thinks that Jim Flaherty is doing nothing but throwing out money, right? He went to buy shoes this week, by the way. But that's what you think. But the only people I know who are throwing money like that are the people who hold stock in J&J and Gilead, okay? Because it's just not going to happen that way in the Canadian environment. So this is the time for the reality check, okay? So you need a reality check. It's nice to be, young and naive, and but reality check here. And those who don't remember the past are doomed to repeat it. So what was the past? Well, the past was that Health Canada approved boceprevir in late July of 2011. 18 days later, they approved telaprevir. They took 3 months at CDR to make a recommendation for boceprevir, and mystically, they took 6 months to make an almost identical recommendation for telaprevir. And then the provinces all dickered around before they finally decided to selectively have public reimbursement for these drugs, with all but 2 provinces in the country putting fibrosis restriction on reimbursement, okay? That is the reality. And PEI, you're out of luck in PEI. You have fantastic mussels and oysters, but you don't get hepatitis C treatment. So you may as well keep eating the mussels and oysters. So that is our reality in the Canadian environment, okay? That is our reality. And so Dr. Shah, an F3 patient, walks into your clinic today at the Western with genotype 1 infection and only public coverage. Can you treat him with a telaprevir-based regimen 30 months after it was approved by Health Canada? And for those who don't work in Ontario, the answer is no, you can't. 30 months after Health Canada approval, okay? That is your reality. So since the first generation DAAs were approved, we now have a new barrier to public reimbursement. It's called the Pan-Canadian Purchasing Alliance. So we're going to have a multiple choice question right now, and I want to know what you guys think. So here's your question. What effect will the PCPA have on the time it takes to get public reimbursement for new medicines? Not just Hep C, new medicines in Canada, okay? Will it, 1, you get your touchpad, vote 1 if you think it's going to accelerate access, 2 if you think it's neutral, or 3 if you think it's going to slow it down. So let's go ahead and do the vote, and when they're in, you'll display that. We'll see. Okay, Dr. Shah, I don't know that I have to say anything further anymore. So only people under 30 were here, I'm sure, if we broke it down by age. Are you still under 30? I don't know. So that's the reality we have here. So you can tell your patients, as Dr. Shah does, that you can defer therapy, but if you do, they're not going to react very well to your suggestion, okay? And in fact, some of them are going to react really badly to that suggestion, okay? Alternatively, you can treat your patients and cure them, and it's not about treatment, it's about getting SVR, absolutely. So that's what I do. I treat my patients, they get an SVR, And then when you look at ratemd.com, you can get that. I rest my case.
Now, this is scarily a true picture of Steve. There's no photoshopping here or anything else. If you just want to sit down because you don't want to go up against him, I wouldn't blame you. Dr. Shah, time for your little rebuttal.
All right, great. So that was fantastic. Steve brought up the very good point that in Ontario, we still don't have telaprevir for that patient. But I will remind him that we had boceprevir for that patient within 3 months after it was approved by CDR. And actually, the table that he showed you with all the various provinces, first of all, PEI does have access. It's just not formally listed on their formulary. But also, the median time to approval across the country was probably somewhere between 8 to 10 months for most provinces. Okay, so that's actually the timeline to keep in mind. So with that in mind, how about a thought exercise here? So the meeting's almost over. We're all going to head home, and we're going to start treating our hepatitis C patients again because that's what Dr. Shafran said we should do. So we're going to start boceprevir and telaprevir in 100 treatment-naive genotype 1 patients. Let's say 30 of them are cirrhotic and 70 are not cirrhotic. All right? Out of those non-cirrhotic patients, we're going to give a very generous SVR rate of 80% and say 56 of them will be cured. And out of our cirrhotic patients, we're going to say 60% or 18 will be cured. At the end of 48 weeks, we'll have cured 74 patients of hepatitis C. Now, let's say we're going to use cimeprevir and sofosbuvir together because we sort of live in that world. Bear with me here. We have 100 treatment-naive patients. 30 of them are cirrhotic, 70 are non-cirrhotic. We sort of go down the graph. At the end of 12 weeks, we'll have cured 92 patients of hepatitis C. Unfortunately, some of the labels are cut off here. But now imagine that we don't want to start the patients at the same time, but we want them to finish at the same time. Because that's the point where truly they'll be cured. And that's where we start to see that separation on that graph that we've looked at already about all-cause mortality. So suppose it's February 15th. Okay, you got some approvals by the end of this week, and you've started patients on treatment. On January 23rd, 2015, you will have finished treatment for your sort of patient group here and cured 74 patients. Now, unfortunately, you can't see the labels here, but if you wanted this group to finish on January 23rd, 2015, you would only have had to start October 31st of this year. So between February and October, that's already 8 months. So if you think it's going to take way, way, way longer than 8 months for us to get approval for therapies in this country, then you should do what Dr. Shafran says. You should go ahead and treat. But if you think history is any guide and that most of the country will have approval somewhere between 8 and 12 months, which is what I think we all hope for and expect, then it makes sense to wait based on this thought exercise. And you could do the same thing with sofosbuvir peg-riba-based triple therapy. You may say, well, we're not going to get access to cimeprevir-sofosbuvir combination. But even if you do that, you will have started later and cured more patients. The delta there is 13 patients, even with sofosbuvir-based triple therapy. And you could do this exercise with cimeprevir as well, which I won't. So, there are many reasons to decide about what side of the fence you sit on here with this debate. But I think that, in conclusion, it's really about who do you trust. Do you trust me, Hamid the Truth Shah? That's my nickname back at the West Room. Or do you trust the man who's pulled an argument out of really the depths of a fiery lava pit, Stephen Shafran? Or, you may not know this, but Dr. Shafran is interim division head of his division. He was previously a division head for a long time, and this is actually how they thought he ran his unit, Vladimir Shafputrin. And I do believe there was some photoshopping into that RateMD rating, because this is actually what his patients call him over here at the University of Alberta. Thank you very much. It's been fun.
we really have to thank both Steve and Hemant. You guys did a fantastic job, not only with the data, but also with everything else, including Photoshop. Amazing how much you can use these new computers these days. So just in conclusion, before we finish off, have they actually changed your minds? So when you return home, February 15th or whatever it is, what proportion of persons with hepatitis C, genotype 1, stage 2 fibrosis are you going to defer for newer PEG-based molecules? So wait, 10 seconds or 7 seconds. Okay, very good. Do we have last times? Because I forgot all that data, of course. No, but I think it was roughly the same, more or less. So most persons are still deferring. You guys did nothing. For the last 30 minutes, you sat up here and you did nothing. But anyway, okay, well, that was good use of our time. When you return home, what proportion of Hep C Geno 1 cirrhotic patients will you defer for newer PEG-based molecules? And same indices. Yeah. Oh, there's a bit of a break here. Oh, look, you guys did do it, Jay. So a third are actually treating now earlier, and they're actually, so we had people move from this section here deferring into treating a bit sooner. No, they went the other way. Really? They were all deferring, were they? I don't remember. Well, we'll listen to Dr. Shah because he always tells the truth. The rest of us forget. Steve and I forget. So, Hemant. Really, this is what you would do? So the true story after all is he stuck to his principles. He never actually married her. He found another wife, but is still waiting. So I think in overall conclusion, really the take-home messages are we really can eradicate hepatitis C. It's essential to increase screening rates. And the CLF has suggested baby boomers born between 1945 and 1975 should be screened for hepatitis C. I kind of don't like that very much purely because it puts me in a baby boomer population now with my dads. But regardless from that, 1945 to 1975 is what's suggested. As well as don't forget immigrant populations. There's high Hep C rates in that, and we do tend to forget that sometimes. Boceprevir and telaprevir-based therapies are effective. Particularly persons with minimal fibrosis have seen that. And really, the future only gets better. So as you know, you can get cimeprevir and sofosbuvir through extended medical coverage at this point. Cimeprevir is approved through Health Canada in November 2013, and sofosbuvir in December 2013. They're going to go through CDR recommendations from June through essentially October. We don't have best guesses as to, a non-educated guess probably puts things into early next year. I'm not sure. I'm sure it'll be debated in about a year's time, but hopefully next year at Castle we'll actually have these therapies available and be using them. But realistically, PEG-free options are available today. If you do have persons with extended medical coverage, 20-25% of my patients have extended medical coverage, you do have PEG-free molecules available today. And even for those persons who are Geno 2, 3s, who are more challenging, there are options for that. So who is the winner? This was not one of those questions because I would have put my name on all three, but anyway. By vote of applause for the guys. And again, thank you for Castle for sponsoring, as well as Jensen for sponsoring this as well, and Peer Review for sending out all the invitations. We do have some questions which have been sent in, and maybe I'll just go through a couple of those while we just wait, if I can find my questions, while anybody else digs up the courage or digs up the questions. So for Steve or Hemant, and we'll just rotate if you'd like. Can you explain the role of Q80K polymorphism specifically with treatment for cimeprevir? Steve?
You want me to? Or,
I'll just choose. No.
okay.
Wait, who's first?
You can give him the right answer if he's wrong.
Well, it doesn't. Who do you want to answer that?
Sorry?
Who do you?
Sure.
Steve.
So
Okay.
Okay,
you'll take it.
Hemant's going to take it on.
As the non-ID person, I'll probably screw up a few things about the virology. But basically, as I think most of this audience is aware, that there is a pre-existing mutation in genotype 1A that occurs in. So genotype 1A is about 48% of our Canadian-born, Canadian-infected population with Hep C, and about half of those individuals would be positive for Q80K, which basically confers resistance to cimeprevir. If you look at the data, the breakdown from the phase 3 trials, essentially if you are Q80K positive and receive cimeprevir as the only DAA with PEG and RIBA, then it's like you're getting PEG-RIBA dual therapy. So I think in Canada, if you have a patient who you intend to put on Simeprovir as the only DAA, then Q80K testing is mandatory if they're genotype 1A. For genotype 1B, there's not that problem. What will, I think, we'll understand with more clarity as time goes on is whether or not that polymorphism is important when you're talking about 2 DAAs or 3 DAAs together. From the Cosmos data, which we've only ever seen as a press release, which is Simeprovir, Sofosbuvir together, it does not appear to be as potent an issue because even patients who were Q80K positive had SVR rates that were over 85% with just Simeprovir, Sofosbuvir. So I think it may, the importance of it may diminish over time, but it brings up the whole specter of what GIs fear, which is having to talk about resistance even, right?
So, and the Q80K will be apparently available mid to end of February as well. So if you are going to use Simeprovir in genotype 1A, you'll probably be urged to actually do the test to get better differentiation of the response rate. Okay, so the second question, which was emailed in, what patients can be considered for treatment with SimSof? So i.e., the combination as opposed to the PEG-based. Steve?
Well, again, the Cosmos study, which has been presented in abstract form, had 2 cohorts. The first were patients with mild fibrosis up to F2, but they were all null responders to PEG-RIBA, and they did very well. The second cohort were patients with more advanced fibrosis, F3 and F4, and they were a mixture of different patient categories. You know, I don't know that, you know, with an all-DAA, you wouldn't predict that with an all-DAA regimen that the previous interferon response is likely to be a significant factor, although you can't completely exclude that because it may be some measure of the innate immune response. But from the preliminary data, you know, the on-therapy rates were phenomenally high. In Cosmos, it was studied with or without ribavirin, and with the limited ends, it's not looking that ribavirin adds anything but anemia to the regimen. So I wouldn't recommend the addition of ribavirin. So who can have it? Anybody whose drug plan is generous enough to pay for it. And the only group in whom I would have any concerns are people who've already failed a triple, like a protease inhibitor-based regimen, because they may have a protease mutation like R155K, and that could potentially compromise the Simeprovir component of that. But whether if they're treatment naive or they failed a non-DAA containing regimen, then if you have funding, why not?
So if you got the dollars, use it, was basically the answer. With or without ribavirin, yeah, my feeling's about the same as ribavirin. And you actually probably answered the next. So persons who fail previous therapy, those question with regards to, I guess, protease inhibitors as well. But it really doesn't look like there's no data for using a SimSof combination at this point. Questions from the audience? Before I go through any more of these. Okay, there's a couple more. I just wanted the audience to have an opportunity to ask any questions on that. With regards to cirrhosis, what is the role of these new agents in persons with cirrhosis? How do you differentiate and or choose?
You get to do that.
Yeah, so I mean, clearly these new agents have advantages over existing agents when it comes to cirrhosis. I think, you know, SVR is just one side of the coin. The other side of the coin is tolerability. We all have seen the cubic data. We know that our patients that we probably want to treat most desperately are also the patients who have the most difficulty with current PI-based regimens. So I think that's going to be where the big leap is. I will say from an SVR point of view, we are not there yet. We need to see and want to see SVR rates over 90% for all of our patient groups. And our cirrhotics right now with PEG-based therapy are not there. Simeprovir, Sofosbuvir combo therapy, yes, we saw SVR rates over 90% in Cosmos, but I mean, those are small numbers. I think for cirrhotics, it's very true that once you get out into real life, the data can look quite different, and primarily because we're using it in groups that are very different than were included in the studies. I don't know. That's
any additions?
Yeah, in terms of, you know, what's currently or nearly available. Mm-hmm. Yes.
Okay. In persons who have relapsed, what are you going to do? How good is the data?
Well, yeah, relapsers are really the lowest hanging fruit. If you look at the first generation, you know, DAs, boceprevir and telaprevir, in both of the programs, the SVR rates were actually numerically higher in the relapse population than in the naive. And the reason for that is the relapse, they're already pedigreed as interferon-sensitive people, right? A naive population is the whole spectrum of interferon sensitivity that you don't know yet till you treat them with it. So in a naive population, you'll have some ultra-sensitive people who will clear in 4 weeks with just the PEG-RIBA at the one extreme, and then you'll have others who would declare themselves to be null responders at week 12, and with absolutely every gradation in between. Whereas when you take a relapser population, they've cleared virus the last time on PEG-RIBA, so they are by definition interferon-sensitive people. So, and if you look again in those programs, the proportion of patients who met the criteria for shortened therapy was actually higher in the relapse patients than in the naives for the very same reason. So using that same metaphor of low-hanging fruit, like the relapse patient is lower hanging than a naive. So absolutely, we should be treating them.
Preferentially treat our relapses. Yeah.
So let me ask this question. So this has come up, may have come up for people out there. So if you have a relapser who has access to sofosbuvir, simepravir combo therapy, would you prefer to use that? Or you already know they're interferon sensitive, why not use sofosbuvir PEG-RIBA as your interferon containing regimen for someone who's already shown themselves to be interferon sensitive?
You could. I mean, I think that if their plan would support both, you could have the conversation with the patient about what their preference is. The one thing about any treatment-experienced patient when retreating is for them, the PEG-RIBA is the devil they know. Because when you have a naive patient in front of you, you can describe what the usual side effects are, but they may also be jaded by their buddy who took treatment, and if that went well, that's one thing, and if their buddy's treatment didn't go well, that could be quite another. But a person who's already been through one course and now you're talking about it, it's no longer a hypothetical construct. I mean, you know, they knew what it was like the first time. It's not likely to be a whole lot different. And so I think that makes the equation different.
Okay. All right. Any other comments or questions from the audience? All right. Thank you very much, and thank you very much for coming today.
Everybody, that was fun. That was fun.